Here, I'm so excited about this panel. So my name's Kapama Yalpala. I go by KP. I'm a senior fellow and lecturer at the School of Public Health, and I'm the lead for the health track here at the Innovation Summit. So this is my second year, and we really wanted to make sure that we create a space for these conversations around global health and the things that people in this room care about, but I think sometimes don't find their way into these sessions. So we've got a great lineup. But I want to first introduce my new friend, and Dr. Ingrid Katz. We're so happy to have her here as our director of the Yale Institute for Global Health. We're looking at a lot of collaboration opportunities at the intersection of innovation and global health, so I couldn't think of anyone better to moderate this panel. So I'm just going to give a bit of her background. It's a lengthy bio, so I'm going to try to compress it, right? But Dr. Katz is a physician scientist and global health leader whose work bridges research, policy, and practice in HIV, health system strengthening, and global health security. She's our director of the Yale Institute for Global Health. As I mentioned, we're really happy to have her here, where she's leading efforts to expand interdisciplinary collaboration in global health research, clinical care, and educational initiatives across Yale and in partnership with our other global health actors in the US and abroad. In addition, if you can imagine this, she also is the Chief of Evidence and Program Innovation in the Bureau of Global Health Security and Diplomacy at the State Department, where she advances evidence-informed approaches to global health strategy and implementation. She's a physician, public health practitioner. You'll hear more about that, but thank you so much for being here with us, Ingrid, and over to you.
Thank you, KP. You're beyond generous, as always. We are thrilled to see such a wonderful full room today. There are three incredible speakers. And so my job is just, as I was saying to these guys, I'm going to just try to set the table and let them enjoy this wonderful meal with you, this moment. I'm going to give a few reflections, and then I'm going to pass it really over to our speakers. But I think it's worthwhile kind of summarizing where we are right now in global health. I've been calling it, as many have, Global Health 3.0. We are truly at an inflection point, and many people feel this way. I think the landscape is shifting, and that is creating both an urgency and a need to find really smarter, sustainable solutions, but also having this awareness that financing, delivery systems, and innovation is shifting along with it. From the tools that we can see today, and I mean, again, you are all probably in the space of innovation or global health. And I always like to ask, how many of you are mostly kind of entrepreneurs, innovators? Okay, how many of you are more on the global health side? Okay, oh, great, we have a 50-50 split. Okay, great. So, we're thinking this is this perfect intersection of you guys, right? From AI-assisted diagnostics, we have digital health platforms, we have new financing architecture, and it's really unlike, I think, anything that we've seen in a prior generation of global health, particularly for what practitioners have access to. And I think there's a real opportunity here. I always think of transitions as opportunities to lean in, to go from kind of proof of concept to population-level impact. At the Institute here at Yale, we really are trying to think collectively, as KP mentioned, about ways to narrow the gap between discovery, which universities do well, right? We are the generators of knowledge, to delivery, which others on here will speak about. And I think some of the applied and implementation science questions are some of the most critical right now. Really, how do we get it from a lab or a pilot to scale? That's actually why I started in government, is thinking about things at scale. And we can think about private and public partnerships in this ecosystem. For those of you who are building careers in this space, we have some younger generation. I think the work of shaping the next era for global health is going to lie with bright innovators like you. And so I want to commend you for coming out. This is a time of a lot of flux. We older folk who have a few more gray hairs on our head are a little worried that, the younger generation, will they keep that torch going? And I can see bright and clear here that there's a lot of young folks in this room. So I'm really excited to share with you today 3 amazing panelists. They have really been navigating some key questions in the innovation space, but from very different lenses. I'm going to do a brief summary of who they are. Each of them could take their own lengthy summary, and then we're going to ask them to kind of follow up. So Monique Mrazek is a senior health tech industry specialist at IFC, which is the private sector arm for the World Bank. She leads investment in early stage health tech companies delivering innovative technology and business models with high impact potential in emerging markets. She holds a PhD from the London School of Economics, where she also serves as a visiting senior fellow. To her left, we have Sheila Davis, who's the CEO of Partners in Health. She's held multiple cross-site leadership roles at PIH, including chief of the Ebola response, which is unfortunately timely again, chief of clinical operations, and chief nursing officer. She holds a doctorate in nursing and has spent her career serving the poor and marginalized communities all over the world, including over 15 years as an HIV/AIDS activist and clinician. And then next to her, we have Silvana Kader Sinha, who is the founder and chair of Prava Health, which was founded in 2014 and led as CEO for nearly 11 years, building Bangladesh's first fully integrated outpatient healthcare platform with a mission to democratize quality medical care in emerging markets. She holds a JD from Columbia Law School and a master's in public administration from Harvard Kennedy School, and she began her career in international law and development. So you can see we have 3 absolutely distinguished panelists today, and I'm really excited for you to get to know them. And we will leave time at the end for questions from you all, so feel free to start thinking about them. I thought we would maybe just run down the line to start with. I could have, as I said, give lengthier bios, but part of what we want to do is leave a little room for each of you to briefly tell us what drew you to your line of work and what keeps you in it, especially right now.
Great. Well, thank you so much, and thanks for having me, and thanks to KP for the invitation. It's really a privilege to be here, and we were noting it's now a female panel, which is unusual even for us. So I've been working in the space of sort of, I guess, global health, international health, pretty much my entire career. And I've worked both on the public and the private side, but I've been doing investments on the private side in emerging markets since about 2006. And initially that started with sort of larger corporate finance transactions and private equity. And as the venture ecosystem started to evolve, I had the opportunity to move more into our earlier stage. And very early on in my career, I used to work in an infectious disease lab that had a spin-off biotech company, and that was my first taste of startups. And so I was really excited when there was an opportunity to sort of bring my early interest in commercialization of technology together with the work I was doing in international healthcare. And so I've been, really had the privilege now for about 12 years or so to kind of be able to sort of witness the amazing transformation that's starting to happen in the healthcare ecosystems across these markets, and the opportunity to meet amazing entrepreneurs across these markets who are really building really novel and innovative solutions addressing the needs and challenges not only in their local markets, but often in their regional ecosystems. In some cases, building solutions that really can have a global impact. So, pretty interesting things that we're seeing, and so that's kind of what keeps me, in this role. It's just really, this opportunity to work with these entrepreneurs, to making the investment is the first step. Working with them, we take board positions, working with them to sort of help them to scale their companies, helping them to make connections across the ecosystem, and then and now some of that portfolio is starting to see the exits. We actually had one of our portfolio companies had a really successful IPO this year, and I think. I fully agree with Ingrid. I think we're at an interesting inflection point, and even as the World Bank institution, we're at that inflection point where this past January, the World Bank created a new institution called the Knowledge Bank, And the Knowledge Bank is really a creation to bring our focus across entire sectors, both public and private. And it's not just healthcare, we're doing this across education, infrastructure, insurance. And I think it's a really unique period for us as an institution to start thinking, and for me, especially as a healthcare practitioner, how do we think about the system as a whole? And very often we're focused on the public and the private, and there was a gap in between. Things like regulatory, things like governance, contracting, all these things kind of would fall in between. So I think we're at a really interesting point as an institution in this broader inflection point within an ecosystem. So I think it's a pretty exciting time.
Thanks for the invitation. Happy to be here. So my journey I started nursing school in the 80s when HIV was first becoming a big issue in the US. And so my pattern of how I was going to practice as a nurse was very much part of being a social justice advocate. And so my career definitely was in the HIV world for a long time, and then as a young nurse was considered an expert, which seems kind of crazy in your early 30s, but had worked to roll out the HIV treatment in the US. And then when finally, too late, we started treating in other parts of the world, went and worked in South Africa and a number of countries trying to figure out how to roll out ARVs in other places. And worked also as a nurse practitioner in the US at Mass General for a number of years. And then came to PIH in 2010. And Partners in Health is a social justice global health organization. One of our founders was the late Dr. Paul Farmer, who in many senses was the, I think, champion of what we see global health today. We work in 11 countries. We have about 18,000 employees, 99% of which are from those countries in which we work. So we don't have the model of kind of flying people in, which I think was very common in the early days of global health. But part of our goal is to really build and strengthen health systems. And part of that is building capacity for education. So we started, post-earthquake in Haiti, started medical and nursing residency programs as part of our emergency response. And that has been threaded throughout all the places that we currently work. I think this inflection point, as Ingrid mentioned, really has impacted us dramatically. In terms of our work is all centered around supporting the public sector, so we don't build parallel systems. So although we were fortunate that we didn't take a big hit and have to lay off hundreds of people and close like many NGOs, we work as part of a system. So if you pull out all those pieces in the system in a place like Malawi or Lesotho, then the whole structure starts to fall apart. So we're in an interesting time of trying to still deliver quality healthcare where we can, but also trying to fill some of these gaps in commodities, gaps in a lot of how health systems have been functioning. And we're losing progress. People are suffering. I think we've heard the false narrative that the U.S. pulling out didn't cause any deaths, and that's 100% wrong. There's numerous sources I can give people after, but we are at a time where we have to address the immediate suffering, and we have to figure out how to do that. And we also have to figure out how we're building a different global health architecture, global aid architecture. And the system was not a great functioning system. I think those of us who have worked in this a long time can validate that, but to dismantle it overnight without a transition plan has really caused unnecessary suffering. So we're at the intersection right now, and I think what keeps me here is I luckily work with amazing people all around the world and get to learn from them every day. And by far, our strength is in people who are coming to work every day, places like Haiti, places where things are falling apart, and still a commitment to providing care for the people in front of them.
Thank you, and thank you so much for having me. It's really an honor to be here with you. So I came to healthcare in a little bit of a different way than the other panelists. I started my career as a lawyer and practiced international law at big law firms and had some really incredible experiences. I worked for Obama as a foreign policy advisor, and I worked for the World Bank in Afghanistan. And was about a decade out of graduate school and was trying to figure out what I was going to do for the rest of my life. And I was born and raised in the United States, but my family is originally from Bangladesh. I was visiting Bangladesh for a family wedding, and my mom was hospitalized for a basic appendectomy. And it was just a really eye-opening experience. Despite that we were in the VIP suite of one of the fancy private hospitals in Dhaka, the capital, the surgery was delayed. There were all kinds of complications, and we had to airlift her to Bangkok for a second surgery. And a year later, she had a third surgery in Virginia due to complications from the original procedure. And, it just struck me. I had seen the tremendous progress of the Bangladesh economy over the course of my lifetime. Since the late 70s, I'd been visiting every few years. And I knew that it was both, I knew also from my work and my academics that it was one of the fastest growing economies in the world. But what I saw from this experience firsthand was that no amount of money could afford you access to high quality healthcare. And so I became obsessed with trying to solve that problem. And as I dug into the problem more deeply, I realized it was so much bigger than I had even imagined. Every day, thousands of Bangladeshis, and every year, billions of dollars leave the country to access healthcare abroad. I believe having access to healthcare that you can afford and trust is a basic human right, and you shouldn't have to leave your country to get it. And so basically, as I talk to patients, and around the time I started the company, I think it's important to mention this point as we're at an innovation summit. This was 2014. When I would talk to investors, a lot of them would say, oh, why don't you build Uber for healthcare for Bangladesh? It's such a great idea. And this is before people realized the terrible economics of Uber models. But from my conversations with patients in Bangladesh, what I understood was the big issue was that they didn't trust the healthcare system. The average amount of time doctors were spending with patients was 48 seconds. There were only 2 international standard labs in a country of 170 million people. What that means is that there are 10,000 labs that are operating outside the realm of any standards. And 25% of drugs in the market were counterfeit. So I thought, I'm not really interested in building an app to connect people to those things. So what we did was we built the infrastructure and then we layered it with technology. So we basically built a healthcare system. So primary care, secondary care, labs, imaging, and pharmacy. Everything's available both in clinic as well as through remote and virtual care. So we have the physical infrastructure, and then we brought Bangladesh's first patient app, through which you can, initially it was really focused on medical records and appointment bookings, which for our market was very novel in 2018. And then when the pandemic hit, we preponed the launch of telemedicine and e-pharmacy and remote care management tools. To date, we've served nearly 1 million patients with high-quality healthcare in Bangladesh, and we're built a brand that's really a household name in one of the biggest cities in the world. And we've done it really scrappily. I'm really proud of the work that we've been able to do. I led the business for 11 years as the CEO and stepped away into a full-time chair of the board role last year, which is why I'm able to be here with you today. What keeps me in healthcare, and I should also mention, I also sit on the board of PATH, which is a global health nonprofit and the largest recipient of funding from the Bill and Melinda Gates Foundation. So I see the opportunities and the transitions that we're experiencing both on the public side of things with my work with PATH and on the private side with my work with Brava. And, I think healthcare is the biggest opportunity in the world, both on the business side and on the impact side. And so that's really what keeps me in it. I feel so grateful to be able to work in this space, and it's the biggest privilege to be able to provide healthcare to people that they didn't know that they would be able to have. People come up to me in Bangladesh all the time and they thank me and they say, we never thought we could have healthcare like this in our country. And honestly, it just makes me really impatient to build more clinics because 1 million people in a country of 170 million is still just a rounding error. So we think we're just getting started.
That's definitely a good note to end that piece on. I think all of you really touch on both the the critical need that we have globally in this space of health and healthcare. I mean, your point is exactly the right one, that you shouldn't be building an app just to send people to healthcare that they don't trust. And I know that Partners in Health very much espouses that as well, to ensure that people have the healthcare they actually need and deserve. And the piece of financing is also a critical part of this, right? So these shifts in this ecosystem. And I guess maybe first to you, Monique, I mean, I think, as we've talked about here, the health financing ecosystem in low and middle income countries right now is dramatically changing. Sheila pointed out the impacts of that. From where you sit at IFC, what is actually moving capital right now, and where do you see the most promising opportunities for new models that could help fill this space?
Thanks. So we invest globally. So obviously Africa is a big priority, but we also invest across other geographies. So it is a little bit nuanced from region to region. For us, where we come in, and IFC started off more as sort of an investor in more mature assets in healthcare, and sort of about 2014, 15, something like that. We started doing, earlier stage. But earlier stage for us is really sort of, maybe Series A, but largely Series B, Series C, companies that already have some, commercial traction and sort of proven models, and we're investing in the ramp up of the business. And so for us, we also wanted to extend our capital earlier in the ecosystem. So we've been working with a lot of partners in the ecosystem that are, seed and Series A funds that can do smaller, earlier checks. They're closer, they have boots on the ground, they're closer to the ground. Often when we come into these fund managers, we're able to crowd in mobilize other investors to come in alongside of us. And so they're going into these funds. And then we have a program called IFC Catalyst, which is really about building innovation ecosystems. It's not specific to healthcare. Some of them invest in healthcare, but it's about building innovation ecosystems where they don't really exist. So in maybe more challenging, post-conflict countries, or IDA. So it was really kind of building those out. And so we've invested. And I think we're now on our third, going on to our fourth approval for investing really small checks in some of these fund managers. So partly we see our role as being catalytic in helping to bring other investments and other investors to the table to sort of help bring the investments there. And then also working on maybe the more challenging, where we don't necessarily see the immediate commercialization, scalability, sustainability. And we have a program called Upstream at IFC, which has been around now for probably about 5 years, where it's really about using even some non-dilutive capital to unlock challenges in the ecosystem that help bring a company to a stage where commercial capital can kind of crowd into those investments. And in some cases, that's also done with blended finance. So we work really closely with different partners in the ecosystem to sort of to look at some blended finance solutions to maybe unlock maybe more financially challenging business models, but that can deliver strong impact. So I think we're looking at creative ways to do this. But I think ultimately it's been, it's really amazing to see some partners who, especially over the last year, have sort of taken on maybe a different approach to using their capital, whether that is non-dilutive or whether that is dilutive capital, to try to support different pieces of that ecosystem and to unlock some of the challenges in that ecosystem.
And can I just ask a follow-up on that? So when you're looking at some of the private sector models that are attracting serious investment right now, what do you think is the theme that they have in common?
In a way, it's not so different than we've seen in developed markets, right? It's like, for a long time, capital was chasing top-line growth, and it was the same in our markets, and sometimes the deals would move pretty quickly. And so now it's really much more disciplined. I mean, it's really, sort of the demonstration of early product market fit, of whether that be through revenues or through some KPIs or unit economics, a positive unit economics, and sort of that indication, obviously being with something with a large TAM, solving a real need in that market, And those tend to be the ones that are attracting more capital, and those that actually end up building sort of more sustainable business models in the ecosystem.
Yeah, I think that point of solving a real need is so critical. And for all of us in this space, right, there's a lot of potential to build things because it's fabulous and sexy, but is it solving a real need? And I think maybe to go over to you, Silvana, I mean, I think you built your model, and it's an incredible case story. There's actually a Harvard Business School case that was developed around your model, for those who are interested, in a locally grounded solution. You saw the problem and you developed it from the ground up. And that is really, I think, one of the most critical spaces for us to move right now. When you think about kind of growing your amazing healthcare solution, you had to navigate some realities from emerging markets from day one. And I'm wondering, what did you have to get right operationally to make sure that you made it through, and what maybe others may not have gotten right?
So I think, number one, the point that you just made, that you have to be solving a real problem for patients, right? And I think we did that, and we proved the unit economics of our flagship unit in 10 months in November of 2018. And so I think our obsession with patient experience and just really being laser focused on providing our patients with a high quality experience that ensures the quality of the services they're receiving, but also treats them with dignity and respect. We guarantee 15-minute appointments in a country where 48 seconds is the norm. I think that obsession really served us very well and continues to. I mean, our feedback, my favorite meeting of the week when I was the CEO was our feedback meeting, which used to have like 35 people on it. And we had people from all across the company, and we would review all of the feedback that we got that week. And we would brainstorm around how we could have done better and what we could learn from the ways we might have let patients down. And we collected NPS for the first time in our country. I mean, people didn't even know how to really respond to our NPS questions initially in 2018. But I think all of those things really did serve us very well. But I do want to pick up on the financing point, which has been a real education for me, I would say. To this day, Prava has done everything that it's done. There are more case studies written about our model than I can keep up with. We don't have $1 of institutional capital on our cap table. Not because we don't want it, but because it does not exist. And so there is no institutional capital funding early stage healthcare infrastructure in emerging markets. And I would say next level emerging markets. I think in countries like India, there are, and I've had a lot of investors actually say to me, we love your business, let us know when you're ready to come to India. But I think next level markets like Bangladesh, which I would call frontier markets, there's no asset class dedicated to funding businesses like mine. And so that's been a real education, and has been, really eye-opening. When I went to graduate school, I thought the IFC and the Asian Development Bank existed to fund businesses like mine. But what I learned is that that's simply not the case. And so I think it's important for people to realize that, because we would have built our business somewhat differently in terms of getting to profitability much earlier so that we could scale organically, and probably not investing in certain things that we did early on. The tech, we have more tech than a lot of tech companies, but the fact that we have technology plus infrastructure off-puts certain investors. So I will say venture capitalists, the journey of venture capital into emerging markets generally doesn't start with healthcare, to start with. But it does exist, and Monique is making some of those investments from the IFC and in the funds that they're investing in. So it does exist, but those funds often, they want to see a pure play tech business. They're scared of the infrastructure. I had a venture capitalist in Singapore say to me in 2019, "We really like your business. We don't know how to run a lab. We don't know how to value a lab." And that's true. You can't blame them for that, right? And so there are all of these pockets of capital that exist for different kinds of things, but not necessarily for the systems level change that we need in healthcare. And I think that's been the real education. And, I've joked about maybe my next venture will be starting that fund that would make those investments, because as we were talking about when we were prepping, I mean, we lived through the greatest global health crisis of our lifetimes. What we need are more clinics, labs, training institutes. We actually need infrastructure. Tech alone is not going to solve those problems. And so we need more allocations of capital to solve these really big problems in the world.
No, that's such a critical point, and I think really shining a light on that and where you had to navigate without really a real roadmap of what happened. I mean, it's incredible. Even makes your story even more incredible. And I think this kind of goes over to the point you raised. It goes to Sheila, because I think you're talking about big system investments, and governments tended to do that. That's what they were supposed to do, right? They make big investments. PIH works in some of the most complex settings in the world. You are faced with incredible inequities in care. I think traditionally PIH has partnered with governments to kind of help support this development of infrastructure. We also recognize the importance of private sector models to kind of interdigitate here. And I'm wondering, kind of from your perspective, what do you see as the greatest opportunities for these two ecosystems to work together?
Yeah, we definitely need all the parties at the table. So we need private sector, public sector. And I think trying to integrate that as much as possible and not having private sector go like this and public sector kind of go like this, which is often, I think, what happens around healthcare. And I think the poorest, most marginalized are probably not going to benefit as much from private sector at the beginning. The hope eventually it will, but right now, I think most systems, our country included, it's the poorest of the poor do rely on government structures to receive their health care. I think in the places we work, there's so much structural violence, colonialism, so much historical reasons why the vast majority or a big piece of countries' income or revenue is spent on debt and interest is something we can't ignore. I think Haiti is a place where we often hear, "Why are you still in Haiti? We've been there 40 years, and how that government can't get their act together." And there's challenges, obviously, within every place we work. But, of the vast amounts of millions and millions of dollars that went into Haiti post the 2010 earthquake, less than 1% went to the government. It went to NGOs like us. It went to all these other small, faith-based organizations, et cetera. So we have to look at what capacity is within governments. And if we want governments to be able to provide health as a human right and services for the most vulnerable, we have to look at the structures they're living within. I think the America First, Global Health Initiative, which, all the MOUs for the countries we work in were just recently signed, which, basically means the countries are going to have to be able to take on these costs within 2 to 3 years. That's virtually impossible in every place that we work. So it's being set up to fail. And I think we need to take a hard look at the structural violence that has accompanied where most poor countries are and try to figure out how can we do debt forgiveness? How can we really address the full system? Because if not, we're not going to be able to finance our way out of this via aid, which hasn't worked, certainly, and we know that from the past. But this is a time where we can recreate a global architecture. And I think the private sector can play an important role in that, but it can't take the place of a strong public sector infrastructure because that is the safety net for the most vulnerable.
Yeah, I think that couldn't be more well said. I mean, I think a lot of what I'm hearing in the recurring themes from your points is that the core notion of trust. Do people trust the system that's out there? And it's bringing me to a little bit of a pivot around some of our new technologies, specifically AI. And I think probably many of you in this room are invested in this space or connected to this space. There was recently the Pope's encyclical on the risks of AI. I'm sure many of you have read it or been engaged in that discourse. I'm going to maybe walk down the line here as we talk about this, because there is a lot of momentum in AI right now in global health. Each of you probably sees this from slightly different angles. There's financing, there's building with it, there's actually watching what reaches communities. Where are you seeing the most genuine impact? And what needs to really happen if we're going to fully realize the power of this new technology?
So I think from, like I mentioned, we sort of invest across, a variety of middle income and lower income markets. And so where we're seeing adoption obviously varies quite a bit depending on sort of the digital maturity already in that ecosystem, in that market. There's some, sort of prime use cases like in AI and radiology where we've seen some implementation, or AI in pathology. So AI triage is in primary care. AI solutions for workflow and managing allocation of patients, supply chain. So there's been different places. In some regions, like in Latin America, I think we've seen a very quick adoption just for some of these solutions. Some built in house, some partnered, some leveraging larger models that are out there. In other places, we did an investment last year in a company called Cara Health in Senegal, which is really building sort of the data and digital architecture for delivery in the region, and really starting foundationally and building out the data sets, well-structured data sets. It's an incredible team of entrepreneurs who have extensive experience working in the digital tech ecosystem in developed markets, went back to their home markets, and so they're sort of really building some of this foundational. I think that, to your point of what sort of needs to happen, I think obviously regulation is still very nascent when we come to digital. We've definitely seen an evolution in terms of, data privacy, data protection. A number of countries have implemented that. Some have pretty stringent requirements around where data can be used and where data can flow, although you may not have a data center locally to be able to fully implement that. But in terms of sort of the sort of next evolution of what we're going to need in terms of regulation of AI, it's very nascent in a lot of these markets, and certainly I think something that will be in the forefront of conversations as we sort of deepen the focus and integration of some of these solutions in the ecosystem.
Yeah, I think where we're mostly seeing AI take off in places we work is in the radiology space, and a lot around tuberculosis. We're using AI-assisted radiology in the mountains of Lesotho, example, to identify TB early and allow there to be access to care earlier. And very excited about the impact of that in primary care. We're looking at where we can try to ensure that we can widen our scope. I think our biggest concern always, and I don't think this is unique to us, is that it remain people-centered, and that we're having AI and technology augment what people can do in their skills, giving community health workers their ability to do more, but they still need to be hooked back to a health system. And it can't exist by itself. So I think our push, and we see numerous companies going to all the countries we work very much on an individual basis to kind of promote their technology. And the hope is that there could be a way that could be integrated, and it could be country-led when looking at what's available, what's the best fit for that country, what's the best fit for certain areas. It's going so rapidly and so fast. I think we're way behind in this area, as healthcare, I think, is in most places. But I worry about the most vulnerable being left behind in this. And so I think we're really trying to say, yeah, we want to be at the table with you. We don't necessarily know what we're doing, but we'll be there. We have the experts who do care delivery for 8 million people a day. Like, we want to talk to you. We have great, trusting relationships in the community, and we want to make sure that the data is not exploitive, that we are actually using this to improve healthcare. And I think we can get there, but I think it has to be deliberate. And I think we have to bring, the local context to the table too, so we're not losing, I think, big swaths of the globe that don't have access and will be left behind.
Thank you. I think the way I think about AI in healthcare or AI in any industry actually, is it's a feature of the system in which it operates. And it can improve the way the system works, but it can't change the way the system works. So the system itself has to be designed properly to start with. And I think from that perspective, we actually have an opportunity to leapfrog in emerging markets. Because if you look at the doctor's office that you'll go to here in New Haven or in the United States generally, it's really archaic systems that are being used that are very hard to adapt. And the tech that was built in the United States was largely built for billing purposes. It wasn't built to help research or to improve patient outcomes, right? And so when we're starting more from a foundational perspective in a country like Bangladesh, where there's very little digital data to even start with, we have the opportunity to build systems that are interoperable, to build systems that can collect data meaningfully for the purposes of research. And I actually think that's one area where there's real opportunity. Most medical research is based on white men. We only started collecting women's data in my lifetime, right? And so now we have an opportunity to collect data from all over the world, from populations all over the world, so that clinical research is more democratized. I think there's significant opportunity there, but I do think we also have a significant risk of exacerbating the biases that already exist. And so we do need to put those guardrails up from a really starting point to make sure that we don't go down that direction. I worry I noticed there's a lot of longevity companies here at this conference, and it's a very hot area right now. But I think most of the longevity products that are out there are being marketed to the people in this room and not much beyond that, right? And the number one thing we can do to improve longevity in the world is to build a clinic close to every community. If we have a primary care clinic close to every community, we can actually increase life expectancy by 5 to 7 years. So I think we just need to think critically about what we want the AI to help us to accomplish and build that into our system in a meaningful way so that we can achieve the outcomes. But it's not going to happen without intention.
Yeah, well said. I mean, I think we're looking to all of you in this room to make sure that, an amazing technology like AI actually meets the populations that need it most. And as you said, it needs to be grounded in the realities of communities and leveraging systems that are built to serve that purpose, that are directly speaking to communities. So this is obviously an area, there's a lot of deep interest here, and we can absolutely get it right, but it will need thoughtful, engaged leadership. So all of you have that mandate. I'm going to probably try to give maybe one more question across the board, and then we can open up for a little Q&A. I have a few more here, so it's hard for me to tease out which one, but I'm going to go with the big one, which is this idea that we started with, which is this kind of changing landscape, and what this moment probably requires of many of us. And maybe I'll walk down the line one more time if I could. I think we opened this conversation talking about this moment of inflection in global health, and we're thinking about massive changes in funding. We're talking about countries taking ownership of health responses when they are often saddled with tremendous debt burden. And we have a moment where I think many of us are eager to kind of move forward in a way that is actually supportive of countries and supportive of individuals living in these countries. So, across the board, as we think about organizations, whether it's PIH, it's working at the intersection of kind of public systems, philanthropy, community delivery, to new private sector models that are really community-based, to financing some of these innovations. What do you see are the most important opportunities now to get it right? When you're kind of using your platform, the crystal ball you have in the next, let's say, 3 to 5 years. 5 is probably the outer reaches. What are the opportunities? What is the field asking of us right now? And particularly in the tech sector, are there things that you see might be coming down the horizon, investments that could be made that may help steer us in the right direction?
Sure. I think we need to see more creative financing mechanisms. I think we need more flexibility around that. especially given that we've seen a fall in global health funding across the board. And it's not just USAID, even the European countries are reducing their budgets given, pressure on defense on their sides. And so I think we need to think more creatively about philanthropy, about blended finance, and figure out ways to incentivize private philanthropists, private investors, and families to actually solve these big, hairy problems. Because one of the things I've observed in my experience fundraising is a lot of family offices are very curious about investing in healthcare, but they're intimidated by it. So I think there's opportunity for us to try to make it easier for them, and I think there's significant need even on the public side of things for them to make investments or on the charitable side, but I think also on the private side, we need to see that. We have dozens of countries since the turn of the century that have graduated into middle income status. And so the one thing I will say, although I completely agree that the USAID drawdown was done irresponsibly and people are dying and it's terrible, there are countries like Bangladesh that were probably overly dependent on these economies. Bangladesh is now a lower middle income country, right? And so I think it forces the private sector to step up in a different way. And I think that's the challenge and an opportunity.
Yeah, I think ditto to whatever you said. I do think it is an opportunity to have people who didn't often work together sit at the table. Global health was a very insular community for decades, and I think now it's broadening. So there are conversations that do have private sector. There's some pharmaceutical companies that we would have said, we're never sit down with a pharmaceutical company, who are really strong partners in oncology and in other areas. So I think it's forcing these creative conversations, but I think I want to encourage us to make sure that people who are going to be hopefully benefiting are at that table, because I think where we went wrong were solutions being made for other people, not with other people. So I think if we can shift that, I think one thing we're doing too in this world of scarcity, where I think people are being told to do more with less, spread out the way that you're doing your care, or if there's you did multiple interventions, now just choose one. That's really scary, I think, for many of us who have fought really hard for decades to get some really good health improvements. And so what we're doing, in addition to trying to, work on the big picture, is say, we're also going to be antagonist a little bit to the system and double down and say we're going to continue to invest deeply in some places so that these models exist. AI and innovation technology is going to be a big piece of that. But if we all wait and say, we're going to wait till the system fixes itself, or some people too, we're never going to get there. So I think we're in support of what countries are having to do and spread out smaller amounts of money that weren't enough before. But we're also saying, we're building maternal center of excellence in Sierra Leone, place with super high maternal mortality, in this time when people are saying, don't invest in this building and this technology and the whole support system. Like, we're going to double down on that, because we want to be able to show it can work and have these models. And that takes really smart people to help us figure that out. And also see that we can't lose decades of advances that we've made. And so, again, it's the deliberateness of partners sitting down with us to say, how are you going to, really look at maternal mortality in one district in Sierra Leone? Because we need to do that in addition to holding down the fort.
I'm really encouraged by the countries that are themselves taking a lot of ownership over the change that is happening in their ecosystems. And I think it's so important. I think it's fundamental. We had the privilege of hosting our healthcare conference in Indonesia last year. And it was really, the Minister of Health came out, and it was really amazing to see what they're trying to do to both blend universal health care together with digital innovation in their system. And they have some challenging geography to reach. And so, that's, one model that comes to mind. I know Rwanda's done some really interesting things. Brazil this year has a new policy that was just launched to basically create a massive data lake of both public and private sector electronic health records, which then from there to build and create sort of more of a unified record across the whole healthcare ecosystem. So I think there's countries that are doing some really amazing things and taking ownership over what they're doing. I think our, transition as an institution with this knowledge bank sort of reflects the demand on the ground. As part of that, one of our targets is within the next few years to reach 1.5 billion unique patients through the work the World Bank Group as a whole does in healthcare, for example. And so one of the focus areas is, on digital primary care, not just digital, but also clinics, and trying to address some of the challenges that we've had around early stage infrastructure. We've been able to do that in some ways with some funds in Africa. It's been easier for us to launch some of these funds in Africa that can do sort of smaller, earlier stage infrastructure focused checks. But I think there's sort of more of a systematic approach to thinking about things like that. Looking at supply chain and trying to address supply chain access to medical devices. And so really kind of taking a broader sort of, fundamentally anchored in, reaching 1.5 billion, but with quality healthcare. And quality is a huge thing. I'll just make my side point, but quality has been an incredible focus for us as an institution. We actually have a team that just focuses on quality, works with our investees on improving quality. We have something called EPIC, which is an ethical principles in health, and it sort of sits as a separate entity from IFC, but it's really about trying to bring ethical perspectives to delivery of healthcare across these ecosystems. So something that it is considered really important for what we do. So I think, sort of founded in what the countries want to do and what they want to achieve, I think that's fundamentally going to drive how we can support them in doing that, both to the public and private.
Yeah, tremendous. I mean, I would say all of you in each of your spheres have worked so hard to break down silos and cross through lanes that normally aren't easily crossed. And so maybe we're going to now bring it out to this room, which, again, when we started, people raised their hands. Some of you are more on the tech side, some of you are more on the global health side. But this is a great example of spaces that we hope are breaking down silos, that you're talking to one another. So our tremendous speakers covered a lot of ground. Want to hear from folks in the room, and particularly those of you who are interested in kind of entering and growing this space. So I don't know if we have a mic, or should we share our mic up here?
You can
Just share it?
Yeah, you can hear it if they.
You can hear it. It's not being taped. You don't need a mic for that.
I think we're okay.
Okay. Well, then we'll just go around. Go ahead, please. If you could just introduce yourself and maybe just say one line about kind of your background, maybe.
Thank you so much. This was very much informative and joyful. Iman Saleh, I'm a postdoc at School of Public Health. And my phone is ringing. It's 8 days. I have to leave for some specific radio.
Can everyone hear okay? Should we
Yes,
give her a
thank
mic?
you so much.
Okay.
Can't silence it. So thank you so much. I like what you have said, Sheila, about the partnership or doing things right, like the transition, the finance models, fix things rather than just cut off things, believing that they didn't work and then just we're pulling the money away. However, I don't think that because of the scarcity of the money, but it's just the money was shifted somewhere else. So we have competing priorities or competing interests. Not necessarily priorities. So you being here, all of you in this room, working in different disciplines, how do you all find the dialogue where you all find avenues when you can all create this partnership, fixing things the right way in a transitional over time? For instance, if you have talked about like, the training and capacity building, because if you want to do whatever on the ground, you need kind of like, enabling environment. At least like the local capacity should be able to adopt what you are planning to do. So how do you create that? And we talk about data and science, and I just checked the knowledge bank at the World Bank. Thank you for sharing that. So it's all about like partnership and data and data sciences. We have academia, like they're doing great in this sense. How about like we have those shared agenda, bringing the private sector, as you mentioned, and then people speak together, create efficient systems, rather than like, I have to do this, then I have to wait for maybe another year just to train people and make the capacity to the level that they can do what they should be able to do. So if you can tell me, like, from where you are, where are the avenues and what new places or tables, like, we need to create to have those discussions and these partnerships.
I can start.